Hi, thank you for coming. During this presentation, we will be talking about the work that we have been doing to characterize neurological disorders from a multifactorial causal point of view, and how that information can be used to identify personalized therapeutic needs. The majority of the data that I will present corresponds to neurodegeneration. However, we believe that these models can be applied to different neurological disorders. For the purpose of this presentation, I should start describing sad reality. The 10 most sold drugs in the US are only helping around 4 to 25% of all the patients that are taking the drugs. For example, for schizophrenia, the most popular drug is only helping 20% of the patients. For depression, it's only helping 12%, and for multiple sclerosis, it is only helping around 7%. A relevant question, of course, would be why the patients continue taking drugs that we know work for them, and why the medical doctors are continuous prescribing drugs that we know work for the majority of the patients. And a direct reply to that will be because we are still in the times of the generalized medicine. As you know, generalized medicine considers similar risks, similar doses, and similar responses for all the patients with the same clinical diagnosis. By the contrary, personalized medicine proposes to identify the difference in risks, in doses, and in responses that the patients could have. The personalized medicine will be the solution for probably the major issues in the health in the world. However, the main idea of the personalized medicine are coming from 50, 60 years ago or from before, and it is still not practical. From the methodological point of view, there are specific limitations causing this. First, we are still using a low-dimensional and union scale analysis. There is a notable lack of integration of different kinds of informations. Also, there is a significant lack of causal and predictive analysis and an abuse of association results, like the use of correlation and regression for making causal interpretations. And also, we continue to use broad clinical and cognitive categories for the validation of the new subtype of patients that are identified, and these already imply a circularity issue. We have been working to overcome these limitations, and recently we proposed a multifactorial causal model of brain disorganization, according to which the change observed in a given biological factor at a given brain region will be, for example, an increase in the deposition of misfolded proteins, will be related to the local regional interactions between the different biological factors. For example, it will depend on the interaction between the vascular system and the misfolded proteins, that they are highly or strongly interrelated, plus the incoming effects from other brain regions through vascular anatomical connections or through any physical network in the brain, plus incoming effects from external signals, like if the person is taking drugs or if the person is doing physical exercises, which kind of diet is having the person. Mathematically, this kind of model can be translated to a set of differential equations that will be capturing the change in each specific biological factor. And this equation will depend on two main components. First, the matrix 8 that will be reflecting or capturing the interactions between the different biological factors and the propagation through specific networks. And also the matrix U that will be will contain information about any external input that the person is receiving. Dynamic system equations and control theory, as probably you know, are used in many different engineering applications, and I hope, and we are starting to see more and more neuroscience applications using them. They are used in civil engineering, in aerospace, in industrial, mechanical engineering. In practice, all what we need to do is to acquire for each patient different imaging modalities at different time points, and we also can include in the model cognitive and clinical evaluations. Then, for each time point, we can characterize the brain is multifactorial state, quantifying the observed anomalies associated to each specific biological factor. And using the model and this data, we can obtain quantitative measures reflecting or capturing how are the interactions between the different factors and how are the propagation about different physical networks. In addition, we can obtain information about how these interactions and the spread of factor-specific alterations impact or change cognition, the clinical state of the subjects. With these models, we can, these are video, I hope, well, sorry, it's not working. But we can obtain a quantitative idea of the spatiotemporal, it's working now, of the spatiotemporal spreading of factor-specific alterations in the brain and how is that related to disease evolution. This is the spatiotemporal spreading of the anomalies in Alzheimer's disease. In addition, because we have a causal model, we can integrate back in time in order to identify which was the initial triggering event of each specific observed disorder. We did that for a population of around 500 patients from the ARNI database, and we observed that vascular dysregulation is the most likely event triggering Alzheimer's disease, at least for the patients of the Alzheimer's population. There are multiple mechanisms that could explain this. I will not enter in detail, but I should mention that proteins and weight products of the brain are cleansed by the vascular system at the lymphatic flow. And I don't have time for the details, but if you are more interested, you could see this review paper that we published recently. This is interesting, but we didn't talk yet about how this really could help the patients. One of the most interesting and important applications of this model is that if now we are interested in to identify, say, into cause a given desired change in the brain, let's say a reduction in the level of myophotoproteins like amyloid and tau proteins in the brain, then all we will need to do to identify which signal we need to introduce for causing that is to pass the desired change to the right side of the equation, and the signal that we want to identify to the left side of the equation, keeping on the right side all the other terms like the propagation and the interaction between the different biological factors. We applied this model to a population of around 300 patients, again from the ARNI database, and we observed that the patients need different kind of treatments. What we have here in these vectors with in the bar plot is quantitative measures of how effective will be to stop the neurodegeneration in a given patient. We call this the multifactorial intervention fingerprint. It is obtained for each specific person. For this person, we can see that a vascular and a metabolic intervention will be more beneficial than any other kind of intervention. It means that this person will be, could have some benefit following doing physical exercise or having a ketogenic therapy, and ketogenic diet therapy. By the contrary, there are other kinds of patients for which will be more efficient an anti-amyloid and an anti-tau intervention, and there are already some specific drugs for obtaining that. And there are other kinds of patients for which nothing or not any single target intervention will be beneficial. And we are proposing that these patients need multi-target treatments. Then if we try then to see if we could clusterize the patients according to the treatments that they need, we will observe that all the patients can be clearly clustered in different subgroups according to their therapeutic needs. And more interesting, each subgroup is characterized by a specific differential gene expression signature. In addition, we characterize each specific subgroup according to the molecular pathways that they have altered. And we found that patients needing a vascular intervention, for example, have only a few only few molecular pathways altered, and the patients that have a need, for example, neurogenesis or an increasing gray matter density have a significant higher amount of molecular pathways altered. In addition to give information about which are the molecular alterations of each specific subgroup, this kind of analysis also gives information about the progression of the disease. If we go from the inner cycle, that represents those patients that need a vascular intervention, to the cycle of the other side, we will see that there is already an ordering in the biomarkers of the biological factors that are altered. In summary, the multifactorial intervention fingerprint are giving information about which specific biologic components should be targeted at the patient level, also which specific brain regions and specific anatomical vascular connection should be targeted to, and finally, which are the molecular pathways explaining the differences in the observed therapeutic needs. Importantly, if we target other factors, other regions, or other molecular pathways, we will have strong negative effects, larger treatment needs, and higher economical costs. That is exactly what has been happening until now. If you are interested in more details about this method and study, you could see this paper that we just published in NeuroImage. And also all these methods and other methods that we proposed before will be available soon in a multifactorial domain analysis toolbox that will be, of course, open access. Thank you.